So as I was telling you previously, if there is a small tumor without any suspicious lymph nodes, still we'll do a total thyroidectomy with bilateral neck dissection. If there is a larger tumor with suspicious nodes, with positive nodes, we'll do everything the same way as it is done for a node negative patient. But um, the contralateral neck may or may not be considered, but we generally undertake the contralateral neck dissection in all cases. So what do you do for metastatic medullary carcinoma? We do go for local therapy in the form of surgery, that is even if it is metastatic, because the rate of growth of metastatic disease is less compared to the primary disease, and the symptoms are also less compared to the primary disease. So before the patient comes in stridor or difficulty in swallowing or any of those symptoms, we should go for a total thyroidectomy with neck dissection, clear all the disease in the neck, and then for the metastatic disease, we can go for first line, second line, and third line chemotherapies plus minus radiation. So then, as we know that it is a familial disease or a sporadic disease also. So for you have to rule out the familial disease. Why do you need to rule out? Is because there is a role for uh, prophylactic surgery. That is, we can do a total thyroidectomy even before the medullary carcinoma sets in, so that uh, the patients who are at risk will never develop the cancer. Just like we do for a prophylactic mastectomy for BRCA patients, we can do a total thyroidectomy in case of familial medullary carcinoma. There is a role for genetic testing, and by doing RET mutation analysis, if there is a RET mutation positive, or if there is a linkage analysis positive in non-sporadic cases, we have to do a total thyroidectomy for all the first degree relatives, especially in male children, male offsprings. We need to do a total thyroidectomy at the earliest. So then there are some other swellings in the neck which are originating from the thyroid, which could be not derived from the thyroid follicles itself. That is, a thyroid lymphoma can occur. So for this, the treatment is the same as the generalized lymphoma. The only issue is you will get to know only after you have done the total thyroidectomy. So you do the total thyroidectomy, you find a lot of nodes in the neck, but you don't go for like there was a patient in which there was a suspicious Bethesda 5 was given for us in the FNAC, but we did a total thyroidectomy. But incidentally, when we went inside, we found a lot of nodes, central compartment, lateral compartment. So because we didn't have a diagnosis of lymphoma in hand before, we did a total thyroidectomy with central compartment and with the neck dissection, but the histology came out as lymphoma, and we started on medical management for lymphoma. Then there will be some benign tumors like hemangiomas which may also occur, and poorly differentiated malignancies which they cannot be classified as uh, anaplastic carcinoma, but still they are poorly differentiated because they are relatively less aggressive in comparison to the anaplastic carcinoma. So, summarizing, FNAC or frozen diagnosis of medullary carcinoma, you have to do total thyroidectomy with the central compartment with bilateral neck. Papillary carcinoma, high risk, total thyroidectomy, neck dissection for wherever the palpable nodes are there. Low risk, small tumors, we can go for a hemithyroidectomy and observe, or if the patient is not willing to come for recurrent follow-ups, or she's not willing to let go of the thyroid at that time, like she wants to go for one surgery only, Then we go for total thyroidectomy with neck dissection as per the palpation of nodes or imaging. Follicular carcinoma, again, total thyroidectomy is required. Anaplastic carcinoma, if resectable, go for surgery. If not resectable, then you have to go for chemoradiation and pray for the patient. And because that is the reason why thyroid cancer is very good when it is good, but it is very bad when it's bad. So you should take care of all your thyroids as malignant, and if they don't come malignant, well and good. FNAC is always required whenever you're doing a thyroid. Large thyroids, better to go for a CT scan before you, that is a cross-sectional imaging, before you go for surgery, because sometimes it may give you an idea about the extent of the disease, and you can be well prepared before you undergo the surgery. So that concludes my session today.